Amira Saleh with the Long COVID Association, and I want to thank you all for joining us today. We've got Dr. Robert Groysman with us, dual board certified anesthesia and interventional pain management, who treats long COVID before we knew it was COVID or long COVID. Um, Welcome, Dr. Groysman, and thank you for being here.
Thank you, Amira. So I've been treating long COVID since early 2020, even before it was known as long COVID. And I don't know if you guys had a chance to watch the Senate Health Committee meeting on long COVID that was on 2 days ago. And it was about 2 hours and 48 minutes. And I was a little disappointed. The message that I got is that it's mostly hopeless. That no physician really knows what they're doing or can help, and we just need more money to pour into studies. But that's not really true. Yes, we do need to obviously study the treatments, but just as a reminder, the NIH got a grant of $2.1 billion, and what kind of treatments have they developed with the $2.1 billion? Is all I'm going to ask. Um, there are treatments out there. These are using off-label drugs, repurposing medications, stellate ganglion block, vagus nerve stimulation, nicotine patch. There's a lot of other treatment modalities that are available that are very successful and give people their quality of life back. So I wanted to see what you guys thought would be, um, what your thoughts are about this committee hearing if you watched it.
Yeah.
Yeah,
If
Amber is
there,
asking, can people with cysts in the brain have SGBs? Well, what do you mean by cysts? The brain is, pretty much occupying the entire portion of the skull, and anything that grows into the brain is called a space occupying lesion, and can be a problem. So I'm not sure what the stellate ganglion block has to do with cysts in general. If you have increased intracranial pressure, that needs to be addressed first before doing anything, much less a stellate ganglion block. But outside of that, there shouldn't be any contraindications. What are your thoughts on the the committee hearing, Amira?
I felt like, I was so happy they finally had a meeting, but I felt like I was back where a lot of people were 4 years ago and just saying I have a problem. And I worry for how long it's going to take to enact whatever ideas that, get pulled together that are doable. I mean, in the community, we know what can be done and what can help right now until there is a cure. There are lots of treatments and procedures, and just a lot. We have a lot of information to, from all the hard work of not just the recent years, but all the work that was done on MECFS, rheumatology, integrative rheumatology, functional integrative medicine. I mean, all these great disciplines, you basically have to come together and make a plan. And that's essentially what we've been doing as a little community, talking with each other and going, hey, do you know about this? Do you know about that? And, maybe if we pull these all together, we can, do something. And this talking amongst ourselves is the first start, communicating with each other. But I did feel like I was watching something from a few years ago because I already gone and watched thousands of interviews of people through their social media and joined in live streams, many with you. and we've heard other folks' stories, and we've looked at every aspect nearly of the human body, short of sequencing our own genetic material in the group. I mean, I'm just very excited, hoping that it won't take as long to come to an immediate solution. And I think the compassion I saw in the meeting, you know, I could really see the compassion, especially from our senators that experience long COVID themselves. They get it. It's almost like you have to endure this condition to truly get it. And
There was only one senator that came forward as having long COVID, as far as being in the committee.
oh,
Now, obviously,
so, yeah,
the committee doesn't represent every single state senator.
right,
For
right, right.
instance, we don't have any Texas state senators that are in the committee.
Yeah.
Um,
Our senator from the great state of Virginia, he showed a lot of compassion in bringing two long haulers to the meeting. One a parent, and the other one an athlete experiencing long COVID, and it he described that talking amongst his colleagues on the Senate floor, learned that they were sharing some symptoms together, and found out at least three of them experienced long COVID, different age groups, and they know what their journey was like as men ages 40, 60, and 80. They were hearing mostly from women at this meeting, and want to remind folks, you know, long COVID happens to, I mean, can happen uh, in just about, I guess, in just about every person. There's a potential after infection.
it
We're
doesn't
one
discriminate.
infection away.
Yeah, it doesn't discriminate against age,
Right.
gender, race,
Yeah.
or religion.
Yeah.
It um,
Doesn't matter.
yeah,
It's a,
it's
and that should be compelling to pull everybody together and say, just like we put a human being flew all the way to the moon, landed on the moon, and flew off the moon back to the Earth planet, and not only that, landed, I believe, near the US and survived. I mean, that's pretty phenomenal when you think about the distances involved, the accuracy that had to happen, and it had never been done before. So we're dealing with in a way, similar distances, but at the molecular level. We have constellations of microbiomes throughout our body communicating with ourselves. There's a lot of communication happening, and I think a lot is getting disrupted in some way, and we're seeing the full force of our genetic material. You know,
well, a couple of
what
weeks
we're born with.
ago, a lot of the studies that were released focused on gut dysbiosis. In the last 2 or 3 weeks, we've seen way more on mitochondrial dysfunction, and this was shown from muscle biopsies, where they isolated the mitochondria and saw that they were not working the way they should be. And this can certainly explain the underutilization of oxygen. Um, and mitochondria are really the main source for using oxygen to perform um, the oxidative phosphorylation and generating energy in the form of ATP. So if that doesn't work well, yes, you're going to be tired. Yes, you're going to have brain fog. Yes, you're not going to have an ability to exercise. Your reserves are going to be very low. Um, I think we should probably take a look at some of the questions because we had a couple come in. Um, so let's see what we have here. One is a comment. One is from Lucia, probably Italy. I'm guessing. I could be wrong. As the committee has no interest, are you willing to create a group of docs worldwide to work on this issue? I am sure people will be willing to fundraise, then work off the group. My main issue with collaboration is I want to publish something, and in order to publish something, you need to have IRB, which is the governing board that decides what how you do a study and how you write the research paper and everything else, which I don't really have access to because I am not academic. I'm not affiliated with an academic institution. That's why. Sure, I'd be willing to get a group of docs together. There's a few in my Facebook group that seem to be interested, but I'm certainly willing to work with anybody who is willing to collaborate.
Yeah, we found, there was quite a bit of funds dedicated to helping solve the problem, yet um, it, some were not incorporated in the studies. And I guess, as like, for example, whenever we do a study, there should be some genetic sequencing to really know the genotype matches the phenotype of a patient. I mean, I had ancestral DNA done, during my journey to figure out what was wrong with me, and I was totally floored. I didn't expect half. I mean, I'm like an international, every continent person nearly. It really showed how connected we are, and I just found, that my father's probably giggling up from heaven. He used to joke we're leftovers of the Crusades, and my mother from Europe originally. She was actually her ancestors from even more northern Europe, and my dad is mostly Italian, so he would get a kick out of that. I think it would help a lot also knowing from a pharmacogenetic standpoint, knowing what medications from the get-go you can most safely metabolize. If your liver uh, can't metabolize certain things as well, that kind of skews the study from the beginning. And, you want a patient not to endure more difficulty when you're trying to help them, is my understanding. So why not start with something they can safely metabolize and then get true results, and see who the medications, are
Mm,
most likely
I
to
think
help.
Rachel is trying to join us.
Yeah, she was having this is a new interface for us, and she's had a little bit of difficulty hopping in. I'm gonna see if she's maybe I can get her through. 1 second. I can.
Well, I'm gonna look through the questions while you do that. Amber is asking, did they have patient advocates at this meeting? Yes, they did, Amber. They had several women who told their stories about themselves or about their children, and basically, they were gaslighted, and their full experience in how long COVID was dealt with, and that we need to do more. A representative from the Moonshot Project was there. I believe she's a nurse. And there were three MD PhDs, I guess, doctors who are more engaged in research at their academic institutions. I hope that answers your question. Um, Stacy is asking about microcirculation therapy, about having symptom relief. And I'm not sure what microcirculation therapy is, unless you're talking about anticoagulant therapy or something like that. Um, Oh Brother is asking about low dose lithium with low dose fluvoxamine for long COVID. Fluvoxamine has been around for many years, as is lithium. Those are considered very old medications. Is it for long COVID? There's been one paper written on it. I'm not sure yet if this is something that I would recommend or not. Next is from Bernard saying Amira is an inspiring advocate. So congratulations, Amira.
Thank you.
Um, Phil is saying that there are some studies showing reduced blood flow to the brain related to the brain fog. Is there a test to diagnose this, and what treatments are there? There's a non-invasive test you can run using an optic test, basically, um, with sensors on the skull to measure blood flow that way. You can also do it from an MRI standpoint, but however, that's more like a Polaroid shot, so you don't get a full picture as minute to minute or second to second. And the reason for the blood flow hasn't really been elucidated, but I feel that it is from the dysautonomia that's happening. Rachel is asking if there's any advice on correcting low iron levels from long COVID. I'm having long COVID for 3 years and still having low iron. Not sure if it's simple as taking an iron supplement. Any thoughts? So the deal with iron is it is an essential mineral, and obviously we need it for our blood cells, for our red blood cells, in order to be able to carry oxygen. But it's also used in other reactions as well. So the main issue with long COVID is absorption. Are you absorbing the iron? There's a sequence involved for the iron to be absorbed, and if it turns out that it is your gut that's the problem, one way to bypass it is to go intravenously and have the iron delivered through an IV. Um, if it's not your gut, then I would still try supplementing first before going the IV route to see if it can be raised that way. Also, anytime you have increased inflammation or chronic inflammation, you will use or utilize iron more. So your body craves it more, needs it more. So that's another reason for low iron. And the other thing I would check is your hemoglobin. I mean, is it affecting your hemoglobin? If there's deficiency and then there's deficiency. So is the deficiency affecting your red cell production or not? Um,
That could probably be
red
one.
blood cells.
I'm sorry.
Hang
That
on,
could
I'm
be.
not done. It was a breath. I need to breathe. Um, Red blood cells tend to be smaller, called
Yeah.
microcytic, when there's a deficiency of iron. Go ahead, I'm done.
I was going to say it appears that um, one of the earliest little indicators of long COVID um, could be tied to seeing trends in anemia, or moving towards anemia. What may be normal for one person may not be normal for another. So that's another thing I've noticed about measurements and studies. Just even looking at like what a normal glucose level is for someone. For my son, what appears to be a normal level for most of us is he's crashing towards severe hypoglycemia. It's we've got to find ways to somehow leverage this information and use AI and whatever other technology we can to help put the power of knowing something's going on in the hands of people. We have all this data out there in the world, it would be nice if some of it could be used to set up alerts for folks. We can do that with like Resonance Inc. developed that app, My Advocate Long COVID, which they're letting us use for our study. And it gives a person who has at least an internet connection and a smartphone, which the government is helping a lot of low income people, it gives them the power to watch trends in their health and wellness just from their vocal cords, the forced cough vocalization, independent biomarker. It's not something they can fake or it's measured specifically for that person, and it's put up in the cloud and then analyzed against a bunch of data they've collected for forced cough vocalization, and they can tell if you are headed towards wellness or unwellness, and you can establish those parameters with your doctor, and doctors get to see a layout of all the patients in their area at one time and can get alerts proactively. I mean, wouldn't it be nice to you get a phone call before the disaster happens? You're like, you can do something about it before the patient really has, difficulties, to catch it ahead of time. So that's kind of why we're participating and using the software to help with that. Hello, Miss Rachel. Rachel,
We are trying
patient
to bring her
advocate.
in, but she's not. She just drops off usually within a few seconds, so I'm
Yeah.
not sure. Um, let me um, let me address a couple of more questions here because we do have
Oh,
limited
yeah.
time. Amber says, if one receives an SGB, hold on, I lost my question here. Um, and dysautonomia does not resolve, is there a further treatment you recommend? Well, first off, you need to confirm that it's dysautonomia that's causing the symptoms. So diagnose first, then treat. So if it is dysautonomia that's causing your particular symptoms and does not respond to the stellate ganglion block, then I want to look at the stellate ganglion block. Was it done properly? Was it delivered in the proper spot? And just because you received a Horner syndrome does not mean that you had a good stellate ganglion block, because only a little bit of local anesthetic is needed to get onto those sympathetic fibers to cause Horner syndrome, but you need enough to have a complete sympathetic blockade. So you can have the one without the other. So that would be the second thing. Okay.
Could you explain
So
Horner's syndrome to the folks that don't know as much about stellate
sure,
ganglion block?
it's an objective test that we use to show that at least some medication got onto the sympathetic fibers in the neck, in the cervical region, and it is a droopy eye, a red eye, so the white of your eye becomes red, the pupil becomes small, your nostril gets stuffy, and some people get flushing basically at half the face, or half the neck or half the arm, but it's always going to be on the side that's blocked.
Okay.
And those things happen because you are removing the sympathetic input into that side of the face and that side of the neck and that side of the arm. So that's Horner syndrome. But like I said, it doesn't really require that much local anesthetic to cause that, but still not have a good sympathetic blockade. So questioning the stellate ganglion block is important. And if you still think it's dysautonomia and you had a good stellate ganglion block, then I would tackle the dysautonomia different ways. And one of the ways is with um, a vagus nerve stimulation, and the other is with nicotine patch. Those two are really good at targeting different aspects of dysautonomia. And you could do some other indirect exercises, such as breathing exercise, that can help as well. I hope that answers your questions, Amber. And I'm going to move up because I saw a bunch of questions come in. Is there anything that helps reduce brain fog? Yes, there's a lot of things that help reduce brain fog, but The question is what is causing the brain fog? It could be multiple different things. As we just mentioned, mitochondrial dysfunction can do it. Dysautonomia can do it due to um, changes in blood flow. And gut dysbiosis can do it because there's a gut brain axis. And if the gut is not communicating properly with your brain and vice versa, that can cause brain fog. So again, it's more useful to narrow down the diagnosis if you can. There's some general treatments for brain fog that includes low dose naltrexone. Naltrexone is normally used to help people wean off narcotics. It reverses narcotic overdose, but in low doses, it has some interesting features. Next is guanfacine, and this is a medication that's normally used for ADHD. It's one of the few non-stimulating medications. It's an alpha 2 adrenergic um, agonist. In other words, it promotes alpha 2. It's similar to clonidine, which is used for blood pressure. And technically speaking, you can use guanfacine for blood pressure as well. If you have low blood pressure, it's probably not the right mix for you to begin with if you're having issues with blood pressure. Those two are the main ones. There's also a third one. So guanfacine has been used for chronic fatigue syndrome. So has low dose naltrexone. The last one being mestinon, which is pyridostigmine. Now, this is a medication normally used for myasthenia gravis. What it does is it inhibits the acetylcholinesterase inside synaptic clefts. In other words, where nerves kind of make a connection together. And what it does is increases acetylcholine available to the nerves. Okay, I tend to not prescribe that as often because it has several side effects some people can't tolerate. And you can look up cholinergic side effects to know what having too much acetylcholine does to your body. I think Rachel is trying again. I don't know why she's having so much trouble. It's really just clicking a link, unless her internet connection is really bad.
I think it's
Um,
the app on her phone.
well, okay.
It's
So that's basically the non-specific way of addressing brain fog, but there's more specific ways depending on what is actually causing it. Somebody's asking about loss of smell, saying that this person has never lost their sense of smell, but has overactive smell. Anything they can do to get their smell back to normal. That seems to be a feature of MCAS. Um, and occasionally uh, chronic fatigue syndrome. Not typically a feature of long COVID or POTS. There's no specific treatments for that I'm aware of or that I've tried that worked. I wish I had a better answer for you for that. But some people don't just have an increase in smell, they'll have an increase to hearing, an auditory increase, or even a visual increase where the light bothers them, sound bothers them. Um, Next question asks about being perimenopausal, having suggestions for hormone imbalance. Um, Long COVID by itself, even if you weren't perimenopausal, can alter the hormone status. I've had people who have had premature or early onset menopause and changes in menstrual cycle. Um, that's sort of part of long COVID. There's no specific treatment for this, but for those that want it, I have done hormone replacement therapy, and they've actually had documented changes in their hormone levels that I've seen on labs. So if those two criteria exist, then I would offer hormone replacement if the person wanted it.
um, I would remind folks that there's not just one thing that solves everything about long COVID yet, short of never getting COVID in the first place. Uh, it's um, it's such a multidimensional problem. It's like some people think it's one thing happening, another thing happening. I think they're all happening at various intensities throughout the body. And as you work towards, with a plan with the doctor towards recovery, some of these symptoms, improve. And things like tinnitus, can get better. Um, ANA values can improve, gut health can improve. I mean, but it doesn't happen overnight. Everything I've seen is like, a few months, some folks a year, some folks 2 years. I mean, what are you seeing, Dr. G?
Well, I mean, I'm not after correcting lab values. I'm after giving quality of life back. It doesn't matter if a lab value X went from being high to being normal. So what if the person doesn't feel any better?
Right.
So, I mean, we don't treat labs, we don't treat imaging, we treat people. That's very important. Labs are there just as an adjunct to help with diagnosis and to monitor treatment, but um, not to basically, hey, we lowered your
No,
this
no, no.
variable.
Yeah.
Congratulations, you're done. You're healthy. Go.
What I meant was
Um,
like the time to improve and recover. I mean, the earlier you begin interventions, the
I
better
found
you'll
that
start to feel.
some conditions respond better if you treat them earlier. Some don't seem to matter whether you treat them early or later. So I've narrowed it down to three main sources, three main causes, with everything else being ancillary or as basically a result of this. And you know my theory. It's
Mm.
dysautonomia, it's gut dysbiosis, and it's mitochondrial dysfunction. Those three things can explain everything else that happens in long COVID. I think everybody has some percentage of these three. And depending on which one is kind of dominant in your body, changes in how your symptoms work. And there's so many different combinations between percentages between these.
Yeah.
Some people have more gut involvement, some people have more mitochondrial involvement. I think by narrowing down to which ones are the main ones and treating those, the majority of the symptoms go away. You may not have a complete cure, but it gets pretty damn close. Um, so, next question is from a Facebook user. And by the way, any Facebook user, if you go, um, where is it? If you go to that link I posted earlier, to chat.restream.io/FB, you can actually put your information in so you're not showing up as Facebook user. It actually uses your name. Anyway, where was I?
Next.
I'm trying to find my way back.
There was a Facebook user you mentioned.
Yeah, I'm trying to find the question again. The problem with being Facebook users, there's a lot of Facebook users right now, and it's hard for me to find what question I was answering. All right, let's see.
Did want to
So
let
we talked
folks.
about.
Oh, I was going to let
Sorry,
folks
my
know that.
pause. Go ahead.
I was just going to let folks know we do these every 2 weeks. Um, and we're alternating times so that folks in other countries can have a chance to join in. alternate between
So
10 a.m. Central
I
and
found I found the question though.
okay.
What route are you taking for the issues of mitochondria? I went back to work part time last week, and over the weekend I was just floored. So it feels like my mito isn't working as it should. I'm guessing you're talking about either chronic fatigue or you're talking about post exertional malaise. They certainly can be caused by mitochondrial dysfunction. I'd like to do some blood work and check muscle strength, things like that. I don't do muscle biopsies or colon biopsies or anything like that in my clinic. I don't think it's necessary to narrow down that the mitochondria is the cause. Um, I've posted kind of a starting protocol on my Facebook group, COVID Institute, long COVID treatments and success stories, where to start. Um, if you want personal advice, though, on what to take, that for that we need to do a consult, and I do offer telemedicine consults, pretty much worldwide, and in 240 languages. Yes, I'm that fluent. No, I'm not. We actually use a translator for that, but it's available. So the point is it's really individualized, kind of where the treatment goes depending on your particular circumstances, what medications you're on, what other medical problems you have. Stacy is asking about IV therapy with glutathione and NAD. Well, it's actually not a question, it's a statement. So I will move on. Stacy saying something about microcirculation therapy using an FDA approved medical device. I'm still not understanding what you're asking, Stacy. So if you want to ask a question, I would, just like Jeopardy, I would ask it in the form of a question so I can answer it. Um, to Lucia, who is asking a question about mitochondrial training through hyperoxy training. I'm not sure, hypoxy. I'm not exactly sure what you mean by that, but when you have somebody who has been beaten up by 20 guys and is lying bleeding on the ground with one eye, not being able to open, I don't know if that's the right time to pick him up and say, "All right, champ, let's go. I'm gonna put you on the punching bag. Time to train for your next encounter." So it's already stressed out from oxidative stress. It's already beaten up. Um, my point is probably not the best time to be doing conditioning at that time. Um, what are my let's see here. Somebody's asking about being on all kinds of supplements and prescription and over-the-counter medications. Should we be concerned about eventual kidney or liver issues? And if so, how to best avoid not including stopping the supplement? I mean, everything you take is going to be metabolized by the liver for the most part. Some things are not metabolized and are just excreted in the kidney. So just taking a lot of things doesn't mean that you're stressing your kidneys or liver out. Um, there are certain medications that can stress your liver and can damage your kidneys, but that's really beyond the scope of what I can do. During a podcast like this. Somebody is asking a question about what would be most beneficial for post-exertional malaise, fatigue, muscle pain, and brain fog. Well, I already mentioned a few medications that tend to work well for brain fog, not just in long COVID, but also in chronic fatigue syndrome, in POTS, and several other related conditions. Regarding the fatigue and the post exertional malaise, again, getting to the source of the problem is more muscle pain, muscle aches, myalgias are is a very non-specific symptom or syndrome that occurs with. Um, so there's a lot of different ways to treat it, including just symptomatically. Somebody's asking about differentiating MCAS versus histamine intolerance. Histamine intolerance comes from one of several mechanisms. One is that you're taking in a lot of histamine from your diet, and that can happen if you have a lot of leftovers that sit around. Histamine tends to develop in bacteria that are in your food that just produce histamine that way. Fermented foods, for instance, um, those bacteria tend to produce histamine as well. And the second would be your internal production. So your microbiome can produce histamine to kind of help you out, even if you're not asking for the help, but they're still helping you out because you're giving them the precursor to it, which is histidine, and that's present as an amino acid in your foods. And the last is destruction. You know, if you're not destroying or eliminating histamine, that causes histamine intolerance as well. MCAS is very different. MCAS does not necessarily involve a lot of histamine. What it involves is inappropriate degranulation of mast cells. So basically, one of the components of mast cells, which is a white blood cell, it's uh, it's an assassin. It tends to have a lot of arsenal in its cytoplasm inside its body, and one, but it has a lot of other digestive enzymes. It has enzymes that destroy RNA, DNA, protein, fat, you name it. It's in there. So what happens is that mast cells are only supposed to degranulate when they have a signal from IgE, which is an antibody that is produced in response to certain allergies or pathogens, um, parasites. And when it binds, it releases its content, hopefully within the vicinity of the offending pathogen. But with MCAS, this kind of happens for no reason at all. The triggers can be anything, anything from heat to a certain food to even being touched. That's called dermographia that can happen with MCAS, and you can actually write on your skin, and it will remain wherever you put the line in. That's where it's going to remain for more than a few minutes. I mean, it could be hours. So that's kind of the main difference. When we're looking at diagnosis, we look for things that would be present with a mast cell, but would not be necessarily present with histamine if it was just a histamine intolerance. Do you
There
want to read
seems to
one?
be a little bit of a connection. I was just gonna bring up, I always like bringing this up, this pattern of Ehlers-Danlos or Ehlers-Danlos like pattern I've been seeing in a lot of folks that end up with a diagnosis of long COVID, and then they find out that they might have hyper Ehlers-Danlos syndrome um, after years of not really showing many clinical signs of it. But after COVID, they have real wonky joints and subluxations, dislocations, uh, joints, in their hands, just knuckles popping out. I mean, all kind of things that they managed their whole life to get away with not happening, and it happens to express itself in such a way. And it seems like that's another thing that could be, possibly looked at. It would be interesting to look at it in groups of patients to see if it's maybe a predictor, to
Well,
people.
EDS does put you at risk for developing long COVID because it can damage your autonomic nervous system. You can have subclinical EDS, but EDS is a genetic condition. It can be found from mutation or mutations. There's actually a spectrum of EDS-like conditions. I'm not sure from the long COVID standpoint if you're implying that long COVID can cause EDS. I think it can cause more EDS-like syndrome rather than actual EDS because I don't think
Yeah.
it's modifying your DNA or causing a mutation.
I think what could be happening is that, with so much of our genetic material actually belonging to the microbiome in our gut, when that gut microbiome gets altered, things that normally were kept at bay or not really expressed aren't, I guess the signaling is changing in such a way. And some things that were kept under control through the gut, the gut microbial species. I mean, this is all my hypothesis, that they're now, because they're not there, those species may be knocked out, or some of their species may not be in enough force. It allows these things to, the signal to go to that mast cell to dump itself wherever. I mean,
Uh, I'm not looking at that way. I mean, if you want to look at it from that standpoint, you would unlock autoimmune conditions
yeah,
and possibly cancer or oncogenesis in those cases where your immune system was keeping things in check.
yeah,
But I don't think it would be something like um, it's dysregulation.
yeah.
It's not necessarily immune suppression.
Also,
It's not an overactive immune system. It's not an underactive immune system. It's dysregulated.
one other thing, in cats, there's a coronavirus, feline enteric coronavirus, that is endemic in the cat population, and in certain environments where there is excessive crowding and uh, not, like breeders that overbreed the animals. Um, the the cat can develop a condition called, the gene actually changes in the gut to FIP, feline infectious peritonitis. Um, Apparently, the gene actually alters in the gut, and I often wondered, is something like that similarly happening? Um,
Well, we don't have enough
yeah, I
information
mean, this is
to
theoretical.
say that happened. So I don't want to really comment on something that we don't really have any data
We
on.
need data. We need funding to study all these things. Um, let's see. Uh,
Next question looks like it's from Facebook user. Um, how does one know if LDN is still working? Or maybe I can better ask, can LDN stop working? I asked because they immediately worked for me in April and I got out of bed and steadily improvements, but since huge relapse in August, I have never felt well again. So the issue with some of these medications is we're kind of addressing the symptoms rather than the cause. So yes, they work on fatigue and they work on brain fog. For some, not all. We're still not 100% sure how they work. It may be an anti-inflammatory effect in the brain. but we're not addressing the cause, so the cause is still there. And if something changes, it can basically undo what the low dose naltrexone is doing. Um,
So
we
your
have a
approach
question.
is more of a comprehensive one. The Facebook user, if they had a comprehensive program, they
Well,
might
yes,
continue to improve.
that's really the only way. I mean, unless you just happen to be lucky and find the right herb or medication that helps you, it's a comprehensive approach. You have to approach it
Yeah,
from several different angles. You have to narrow down which of the causation factors is your most prominent one. Sometimes it's all three, and you have to address all three. Sometimes it's
yeah,
one, and if you address that one, the symptoms will go away. Not by chasing the symptoms, but by treating the cause.
right. Yeah.
David is asking about having an additional SGB if there was no response. Um, should there be one or two? If there was a response, but it dissipated. So if you've had a good response to the stellar ganglion block and it was done well, then I would repeat it. There's no reason not to. If the block lasts a short time and the second one lasts a short time, then the next step would be to do something like radio frequency. And I prefer to do pulsed over ablation. I don't like destroying tissue. I prefer just doing a stunning of the tissue, and it works. It works most of the time. It doesn't work 100% of the time, but it does work most of the time. I've had patients who were resistant to the stellate ganglion block. In other words, they got a good response, but it went away right after the block went, resolved, or within the next day or two. And they're getting a response. It's just not lasting, which means their bodies need a longer time to be blocked on the sympathetic side for it to work. And we've proven that by doing the pulsed radio frequency, where after that they maintain their recovery.
Hmm.
Somebody asked about. Hang on.
What tests would you use to
I'm seeing a
determine?
lot of questions fly by, so it's kind of hard.
I see the next
Uh,
one. Um,
but somebody asked about cryoablation versus a stellate ganglion block. That's probably later on, but I saw it pop through.
okay.
Um, Anytime you have the word ablation in there, which means destruction, ablation equals destruction. So, like I said, I don't, whether it's radio frequency or cryo, if you're ablating the stellate ganglion block, I don't think that's a good idea. Even if it regenerates at some point, it's not necessary. I think it's too destructive. And stellate ganglion block is just a temporary block, anywhere from an hour to 4 hours, depending on the medications used. Whereas any kind of ablation may be permanent. Now it may resolve and come back, but I'm not in favor of an ablative method on a stellate ganglion. Thanks. Let's move on to Facebook user. Question about post-exertional malaise. If LDN or other medicine supplement camouflage the symptoms, long COVID, PEM, or any other problem worse or help cure? I believe it's more symptomatic control. If we're talking about something like low dose naltrexone for post exertional malaise, in my mind, post exertional malaise is mostly going to be caused by mitochondrial dysfunction. It tends to be even resistant to an SGB. Um, and I think there's the mitochondrial issue that's going on alongside it that's causing the post-exertional malaise. So yes, you can treat the symptoms, you can mask the symptoms, you'll feel better for sure. And I do that as well. I mean, you can't always wait for the causation treatment because those take time. Sometimes you have to treat the symptoms until you treat the problem. I hope that makes sense.
Um,
Um, Regarding tests for mitochondrial dysfunction, I focus on lactate and pyruvate and creatine kinase as blood tests for mitochondria. However, they're not going to be 100% diagnostic, okay? Because a lot of things can make those variables high or low. It's in conjunction with symptoms and everything else going on that I make my diagnosis. Nothing is going to be made by lab or imaging, okay? So Phil is asking about POTS after COVID. So yes, heart rate jumps of 30 plus when standing is basically how you define POTS. Um, what is POTS? It's postural orthostatic tachycardia syndrome. So there's two words in there that are important. Well, actually three, but orthostatic, and that means upright. So anytime you're upright, something changes in your body. And the other is tachycardia. That's what's happening. Your body normally, when you're laying down supine, that is flat, parallel to the floor, your blood will pool in your gut, in the bottom portion of your gut, and in your legs. And when you stand up, what is supposed to happen is your heart rate will increase temporarily for maybe the first 30 seconds to a minute, while your autonomic nervous system squeezes your arteries and veins in your legs to push that blood back up to the heart. Because from the heart standpoint, it all of a sudden sees, I have less blood than I had before. And it reacts reflexively by pumping harder and faster. That's what's supposed to happen. But when your legs squeeze down and your gut squeezes down, the splanchnic circulation squeezes down, that blood is forced back into the heart, and the heart says, "Oh, everything is fine," and it slows down and calms down with the force of the beats. In POTS, that happens very sluggishly. So it does happen. It's just very, very slow. Now, if it doesn't happen at all, you have what's called orthostatic hypotension. And your heart will not be able to compensate by beating faster and harder because there's decreased volume coming in and your legs are not squeezing down, and your blood pressure will drop. And when your blood pressure will drop, you'll pass out because there's not enough blood going to your brain. And it only takes a few seconds for that to manifest. So that's basically POTS and orthostatic hypotension, not hypo. So you can treat POTS in two different ways. You could treat it symptomatically, or you can go after the dysautonomia issues. Symptomatically means compression garments, basically from belly button down, you squeeze. Therefore, you're taking the place of what normally should happen and force the blood up to your heart when you're standing up, because the issue comes up when you're standing, not when you're laying down or sitting. Yes, it's being recorded, by the way. I know some people are asking. So that's the first thing. The second thing is increasing fluid intake and salt intake. We're trying to replace the volume that the heart is missing when you're standing. The third is increasing salt absorption with certain medications. The fourth is there's a medication known to vasoconstrict called midodrine. That's more useful, for instance, in orthostatic hypotension, but it basically squeezes the blood pressure. If you have high blood pressure already, this is not the medicine for you. If you have hyperadrenergic POTS, in other words, your blood pressure goes up when you stand up instead of down, that's not the medicine for you. Some cardiologists will treat with either beta blockers, calcium channel blockers, or another medication that basically slows the heart rate down. So if you just have POTS, not orthostatic hypotension, in other words, your blood pressure doesn't drop, really your symptoms are caused by a fast heart rate. And the reason is because after it gets to a certain point, if it's beating higher than your heart is able to fill, the same thing happens. It's not able to actually output the blood to your brain because it doesn't have enough coming in because it's beating so fast. Um, so essentially, the tachycardia becomes the problem. Um, Even though it's trying to compensate, it can't after a certain point, and you feel dizzy or pass out. Even though your blood pressure is okay, but your heart can't process the blood because it's going so fast. It's kind of like an engine. It has limits on its RPM, right? You can't go beyond a certain RPM because it won't work. There's not enough fuel and there's not enough oxygen that can make it into the chamber before the next cycle begins. Same thing in the heart. Um, so that's essentially how POTS is managed, or you can go after dysautonomia.
Okay.
How do you prevent getting COVID again? Well, that's a very loaded question. I mean, there's really no surefire way unless you want to move into Antarctica or the Arctic and live in an igloo with no contact with people or anybody else. Um, there's nothing that will guarantee never getting sick again, unfortunately. I wish I had a better answer for
Yeah.
you. But good news, China is developing another COVID virus that attacks the brain. So don't worry, COVID will be forgotten very soon because we'll all be walking around like zombies when it attacks the brain. So um, that's not going to be an issue anymore. I know, I'm being facetious, but sometimes a little levity is required. Um, I tell you. What are your thoughts about COVID and reactivated ABV? Well, it's one of the markers. So there was a study that was released looking at the herpes family of viruses, and Epstein-Barr virus is one. CMV virus is another. It's called cytomegalovirus, and chickenpox, which is herpes zoster. Those three, for instance, if they reactivate, um, it pretty much indicates that you have long COVID. I mean, it's a great biomarker to look if you have COVID. Is it contributing to long COVID? Possibly. We don't know. We don't know. Not everybody has reactivations. It can cause the same symptoms that you had initially with mononucleosis or mono. It can rarely infect the liver. It can rarely infect the lungs, causing a pneumonia. It can rarely affect the nervous system, causing encephalitis. These are rare. Those require treatment. Um, in the context of long COVID, um, I discuss it with the patient if it makes sense to treat or not, if there's a reactivation. But you can clearly tell if it's reactivated or not. Deidre, your question I already answered about the cryoablation. Boy, it's a long one. I don't have a question in there though.
There was one, you know, that we went over kind of quick about to prevent getting COVID again. There, like you said, there's not one specific thing you can do, but there are mitigation strategies. Keeping.
I mean, you can gargle, I mean, there's other things you can do, sure, but none of them are guaranteed
Yeah,
to prevent. That was my point.
yeah,
I mean, yes, you can mitigate it, um, but there's nothing that's guaranteed to prevent it. It's a virus.
right. I just if
It's a virus.
some of those things are minimizing stress, nutrition, getting good sleep, everything you do to take care of your immune system takes care of you against any of these pathogens. So you can look at it from a strategy like that. Take care of your gut friendlies. I call them gut friendlies, the ones that help take care of us. I even drew a cartoon. Ah,
So
good
I
question.
figured out you could just have the message pop up. What can you do naturally to regulate our autonomic nervous system? So there's several things you can do, Rachel. One is breathing exercises. So one good one is box breathing, and it's basically 4 seconds inhale, 4 seconds hold, 4 seconds exhale, 4 seconds hold. If you can't do it for 4 seconds, do it for 3 seconds, or 2 seconds, or 1 second. You could build up to it. Humming, singing, doing anything relaxing
Laughing.
can help activate your parasympathetic nervous system. I'm not a big fan of cold water, ice water, face dunks, or carotid massage because sometimes you let something loose that you don't want. But I mean, you can look up different exercises for vagus nerve and parasympathetic. There's plenty. But that's really how
I
you regulate your autonomic nervous system.
I actually saw an app that simulates the cat purring to improve your vagus nerve. There was a paper
Sure,
written
certain
on it.
sounds can do it too.
What
Yep,
can?
certain sounds can do it. Sounds can do it too.
Yeah,
Anything you enjoy, really, anything that brings you joy, can put you back.
yeah.
Oh, I got something from Rachel, but I don't see her.
Let's see.
Rachel says she's back,
There she is. She came back.
but I don't know where she is though.
We have we'll
I don't know where she's at.
we'll work on this interface to, you know, hopefully we'll be able to integrate it to the
Uh,
that's the
this is
tool that they're
the
familiar
last
with.
question that I have right now. How do we get an SUV done outside your territory? We cannot all come to Texas. Um, Unfortunately, the block I do is not a standard stellate ganglion block. I call it an evolved block. And you really will not be able to find it anywhere in the world the way I do it. This is not, ego or anything. It's just a fact. I've developed the technique and the method, um, and that's the reason that we have such great results with this procedure. And I don't even technically call it a stellate ganglion block anymore. Um,
Let's see.
I think that's about it for the questions. What else do we want to talk about in the last couple of minutes here?
Um, let's see. I I would let folks know we love to hear from them. What particular specific topics you want us to cover more in depth, and uh,
I think for long COVID clinics, if you're seeing other doctors, if you're going to long COVID clinics, you should be doing most of the talking, and they should be listening. And once you're done, they should be asking you questions. So if they're not asking you questions or they're doing all the talking, you're not really going to get anywhere. A lot of this is going to be history. There's nothing really to examine here. I mean, sometimes you'll get rashes um, or I guess some weird presentation, but most of the time there's nothing really to examine. So it's all about listening and asking the questions. And yes, labs are important, but they're not as important as the history and the questions. So I know some places, you walk in and you get the full catalog of labs, 300 plus labs, plus 3 sets of imaging, plus, 2 gut maps. And what are you doing with all that information? The patients come see me with a stack of labs this big, and I ask a question, what were you told about these labs? And a lot of times, I don't get an answer. Why was this ordered? What were you looking for? So you shouldn't be ordering labs unless you're confirming something or ruling something out. I've had patients in the Facebook group, present tests, and I said, "Well, why was this ordered?" I don't know. What is your doctor doing about it? Doesn't know what to do about it. You ordered a test. You didn't know what it was for. You don't know how to read the results, and you can't do anything about it. Um, yeah, that's not how I was trained. So Deidre is asking about treating a Horner syndrome if they don't subside. If they don't subside, you got a problem. You got a problem, Deidre, because that indicates damage to several possible neurologic areas. I mean, normally, if you see Horners without a block, it usually signifies pathology. It could be first order, it could be second order. It's difficult to say without doing some tests. But if this was caused by a block and it's not going away, something was damaged. And yeah, like I said, this is an advanced block, and you really kind of need to know what you're doing. Um, you need to know your anatomy super, super well. You need to know all of the variations in anatomy super well. You need to know where you can and can't go. So I'm not sure if you're asking if this was done post block or not, or not. So, but if you have it post block and it's been more than a day or two and it hasn't gone away, something is probably damaged in there. It's the best I can tell you. Yes, I know about ruling out other conditions and causes, and I do as well, but I don't order 300 tests, 300 blood tests. I do a focused exam and focused ordering of blood work, likely culprits, if I'm considering them as a culprit. For instance, if you don't have any pain in your body or your joints, I'm not going to be looking at rheumatoid arthritis or lupus. Which is kind of an important symptom. So, I mean, I use symptoms and exam as guidance to order. Rachel is saying something. Do you want to read it?
Rachel says, I have a suggestion. We should create a fashion protective space suit to go outside to handle our business or to see our doctor's appointment. Yeah, she's concerned, like a lot of folks, about immune dysregulation and being immunocompromised after uh, at least one COVID infection. Some folks have had more than one COVID infection, and with every assault on their system, their immunity is more and more at risk for so many other secondary infections and more at risk for cancers and all the other things that are possible after after COVID. And she was saying, since um, a lot of the mitigation strategies in the public space, particularly public healthcare spaces, don't require masking It's
You can still wear one if you
yeah,
want to, if it makes you feel safer. I
yeah.
mean, I'm still kind of going back and forth on this masking thing. I know a few people have commented that it doesn't really change anything or help because the virus is so small, and if it's suspended in air, it's mask is not going to stop it. Not even nothing, maybe except that N95 type
Uh,
mask. But if it makes you feel safer to wear a mask, wear a mask. No, no, nobody's saying you can't.
it's not just virus particles, but a lot of people with the MCAS symptoms appearing a lot in their lungs and reactivating lupus. Some folks
Well,
have
MCAS
cancer now.
histamine can affect lungs for sure. I mean, histamine is known to affect lungs and gut. Those are the two main areas that you're going to see histamine issues.
Yeah. So some folks are have new chemical sensitivities, things they weren't sensitive to before, smells, certain things. They're now sensitive to it. Some folks were were tolerant of certain medications prior to COVID. After the changes in their gut, they're sensitive to these. They can't take these
Right,
medications anymore. They
right.
require different
That's what MCAS
one.
is.
Yeah. So
I mean, that's what
Rachel's
MCAS is.
really
It's increased
concerned.
allergies, new allergies.
Yeah. And Rachel has a lot of
Okay, but a suit is
concerns.
not going to help with that.
Um, she's like, what else can we implement to keep people safer so they can get to their appointments? I mean, she's a cancer survivor during this pandemic, 2 years, I think, 3 years cancer free, and still surviving long COVID. Um, it's been a lot on her, and she wants to minimize, you know, some some folks are. It's a almost like the lining of a river, and you've got all these sandbags protecting the town, and there's so many and holes that are forming, and things are leaking this way and that way throughout all these different tissues. People are worried, like, how are we supposed to navigate life now? It's like a whole other world, and it's not
You're supposed to just
designed.
navigate life. I mean,
Yeah, it's not designed to
before COVID, we had
accommodate.
something else. I get
Yeah,
it, but this is not, having a pandemic is nothing new. In 1918,
right.
there was the flu epidemic, and they had the same situation. They had nothing to treat it with. And my point is COVID is not going to be the last pandemic that we're going to see. And you just have to learn to live with it. It is what it is. It sucks, but you can't stop living life. And I mean, you could take certain precautions um, by limiting, being in enclosed spaces, by wearing um, an N95 mask if you can, or it's comfortable for you. But there's really no 100% way to prevent getting sick again. Now, some will tell you it's ivermectin or some other medicine, but I don't know about 100%. Okay,
Yeah,
if we're talking about, to make you feel super comfortable, knowing that there's no possible way for you to get infected. I just don't have anything like that. Now, Deidre said she's had a Horner syndrome for 6 months, and like I told you, I mean, it's pretty long acting, and at that point, um, even earlier, I would say, if it's more than 2 or 3 days, you need to have a trip with. You need to have a meeting with a neurologist, and they'll work you up and see kind of what's going on. You may need an MRI. You may need something else, but it's not normal. No, it's not normal for Horners to last for 6 months. It's not normal for Hornets to even last more than a couple of days. Typically, it resolves the same day within a few hours of the block. Um, I've seen it last a day, but never for 6 months. Okay, there's something going on, and it needs to be worked up. Okay, I'm sorry that happened to you, um, and this is why I say, Deidre, that this is an advanced block, and you really need to go to somebody who knows how to do this properly and well and everything. So, I'm sorry that that happened to you, and I don't know if it's gonna get better or not, but there it is. Um, um,
Rachel had a
immune
question,
system,
and Phil.
yes,
Okay.
but Shar had a question before.
Okay.
I watched the Senate committee on long COVID this week. Several people mentioned this as an immune system gone wrong. That's why I say it's dysregulation of the immune system. It's not a immunocompromised situation, and it's not a hyperactive immune system. And the reason I say that is because if you were completely immunocompromised, we wouldn't see things like cytokine storm, because you wouldn't see that in an immunocompromised person. You wouldn't see much of a reaction. If it was overactive, you'd see a ton of autoimmune conditions, which some people do have, but I think it kind of falls into a category of dysregulation, immune dysregulation. Um, and what would be the treatment? That's what we're doing. We're treating the chronic inflammation, which is a result of the immune dysregulation. And like I said, there's multiple sources for this. Guess what? White blood cells have mitochondria too, and actually they use them very often. They're very energy dependent. In order to dump the contents, you need to have energy to contents to the outside of the cell and to move around from one area of the body to another. They don't just use the bloodstream; they crawl. They literally crawl like an amoeba. So that requires a lot of energy. So mitochondria are very important in white blood cells too. All I'm saying is that I think this is a symptom, not cause. The immune dysregulation is coming from one of those three sources that I mentioned earlier.
Um, Phil
So
mentioned,
yes, Rachel hopes that cellular function, yes, but on a more direct is the mitochondrial dysfunction that could be responsible for the immune dysregulation. I'm sorry, what were you
oh,
saying?
there's another Rachel T, and then Phil Aikman, and
All right, we do have a hard stop right at 11:30 though. Okay,
okay, that's why I wanted to check with you. Um,
sure.
Phil Aikman says, you mentioned on one of your YouTube videos that temperature regulation, increasingly feeling cold, is part of long COVID. Any tests worth doing?
So I believe that the temperature dysregulation, whether you're feeling cold or hot, is a direct manifestation of the dysautonomia. The reason is because you have a thermostat in your brain, but it tells your sympathetic and parasympathetic, but mostly sympathetic nervous system, when it's time to dilate the blood vessels under your skin and give off heat, when it's time to sweat. And the parasympathetic does the opposite. It constricts the blood vessels. So when that system is dysregulated, your body temperature is not being regulated properly, even though you're getting the thermostat, but your furnace and your AC in your body are not listening or cooperating. I know I had this issue this summer. I would set my thermostat to something, and my AC just couldn't handle it. It wasn't able to get it to the temperature that I set. So that what you're feeling is that dysregulation. So fixing the dysautonomia is your goal here if you want to address the temperature dysregulation. I hope that helps.
And Rachel T says, I don't understand how I can taste for several seconds and then it's gone. Is there a chance it could come back, meaning her taste, I guess, taste and smell after 3 years, 4 months?
So I believe that the taste and smell problems, whether it's anosmia or parosmia,
Mm.
are also a product of the dysautonomia. It doesn't really seem to respond to other methods of treatment outside of dysautonomia. In general, the longer you have the issues with smell and taste, the more resistant it becomes to treatment. Now, it's specific to those two, not the brain fog, not the fatigue, not the anxiety, but it seems to be specific to the smell and taste. It's possible that your body or your brain is kind of getting used to the new normal, what we call neuroplasticity, and it adopts it as the new normal. Kind of similar things happen after a stroke or after you lose a limb, and they remap those nerves to different areas. Um, it kind of becomes the new normal, even though it wasn't beforehand. So you want to address these as early as possible. If it's coming back even for a few seconds, that tells me it's trying to reboot. So it may be worthwhile to go ahead and try the stellar ganglion or vagus nerve stimulation. I'm pretty sure you're probably doing that already. Um, but but yeah, early treatment is important because it becomes more and more resistant as time goes on. And I'm not saying you can't treat it. It's just it may require more aggressive therapy in order to get you back to recover and keep you there, because it just keeps wanting to go back to the new normal because your body recognizes the new normal. It really is kind of a, I guess, a malfunction in a way. But we accept what we're given, and we just keep living and move on. Um,
I want to
we have
remind folks that we'll be doing this again February 4th in the afternoon, 3:30 Central Standard, 4:30 Eastern Standard. Be sure to follow Dr. Groysman on his social media. All the links are at the top of his page, covidinstitute.org. And of course, please follow me too,
uh,
longcovidassociates.org. And I want to thank you again, Dr. Groysman, for all the time you've generously donated to help the community understand these conditions, strategize, learn how to talk to our doctors. I want to thank you. Really appreciate it.
I wanna you're very welcome, and I wanna answer this last question here that I'm trying to show about POTS, brutal insomnia, sympathetic overdrive. Um, in itself, just saying you have POTS doesn't really tell me anything because there's many different symptoms that can present with POTS. With insomnia, it can be from the sympathetic overdrive, as you mentioned. It can be from excess histamine. Um, it could be for other organic reasons. So I don't know anything about you. So you need to make sure you have good sleep habits and you're not suffering from obstructive sleep apnea, OSA. Um, so first figuring out what the issue is and then going after it. I believe I have mentioned uh, POTS symptomatic treatment. You can also go after it by targeting the sympathetic overdrive with stellate ganglion or vagus nerve. There's a few different ways to do that. Okay, and yeah, I wish they would have invited me to speak as well. I didn't know about the Senate um, the Senate Health meeting.
Yeah.
I think I could have gotten them on the right track, but make no mistake that the people, not the patients, but the docs testifying there, kind of really had one objective, and that's to get more funding um, from Congress, from
I
the Senate,
I did
from the
I
committee.
did reach out to my senator's office a few months ago and got a little thank you letter. Thank you for reaching out to share your ideas. Uh, just one of them, for example, if anybody out there knows how to make this happen, so many people who have long COVID, they're suffering from malnutrition and malabsorption issues, and they need some form of supplementation in their diet or different kinds of foods, and these aren't always covered in their health insurance. And it's also not covered with many of them are on SNAP EBT program, USDA's program. If there's a way to allow or make a vitamin, multivitamin, these nutrients absorbable foods, um, if there's a way that you can help make that happen, that they can make an allowable purchase for some program that's already you know, working and out there to help people, it would help people who are really struggling to get the nutrients in their body to do basic cellular repairs. I mean, just to rebuild the damage, they need to have something that they can absorb and use. So I thought that would be a nice starting point using a system that's already out there helping people. Just, allow them to have a few things nutrition wise that can help.
Hmm. And I will say that the ADA does recognize long COVID as a disability. Not that there's been many disability policies approved for long COVID or vaccine injury, but it's technically out there. And I'd like to end this on saying that basically with what I said in the beginning, I disagree with some of the things said during the Senate Health Committee meeting during for long COVID, and that is, I believe that there's successful treatments out there and they're available. I know because I do them, and there is hope for recovery. So they kind of made it sound that it was hopeless, and we didn't do anything really for the last 3.5 years, and now we need money to do some, to do nothing again. Um, so it's private guys that tend to um, help patients more so than the ones running these studies. Um, it's just the way it is. We're kind of the end users, or end givers, however you wanna call it, similar to a mom and pop shop compared to Walmart or Costco. Um, but anyway,
You
my
all
point is
you all
this.
take care. Oh, go ahead.
My only point is that there is hope for recovery, and there is hope to get better. So I don't want anybody giving up. Um, all
That's
right.
that's a key point.
Any parting
There is hope.
message, Amira?
I'm so,
Any parting message?
I also want to let folks know there is hope and stay tuned. We keep working with each other. You know, we're doing the right things. We're communicating with each other. We're talking with each other. We're listening to each other and believing each other. And I I really I'm so impressed with some of the systems put in place. Dr. Groysman, reached out and said, "How can I help?" And there's a lot of people that need to be educated. I think the meeting last week was a starting point in that it's starting to speak out about it because most people think COVID is over. That's why a lot of people don't bother to mask or social distance or even recognize the sick person who's wearing their mask. Um, Long COVID is a disability recognized by the ADA, like Dr. Groysman said. And as your conditions can change, you can, you know, improve. You might have good days and bad days. You need some accommodation so you can be a part of life. Life, liberty, and the pursuit of happiness. We all deserve happiness, whether you're enabled or disabled, right? So
Right.
we need to help each other, help each other a little more. And I think a lot of us, um, a lot of us do that. Just, try to take a pause sometimes. If you're frustrated with the other person that can't hear what you're saying very well, you never know, they might have tinnitus. Be patient. A lot of people are enduring quite a lot. You may not see it on the outside. It's not an easily viewable condition as a lot of chronic illnesses are. So maybe just like Rachel always says, spread a little kindness, be a little more patient with each other and be kind to yourself and advocate for yourself. So, yeah.
Okay, take it easy, people.
Alrighty. And
Enjoy the rest of your Sunday.
thank you all for tuning in. And we'll see you in a little while. Send us your
Yes,
messages.
in two
Okay.
weeks,
Yes.
3 p.m. 3 p.m. Central Standard in 2 weeks. Thank
Okay.
you.